analysis of the dental and skeletal relationship of the skull, and assessment of the position of impacted supernumerary. We can estimate the presence or absence to prove the resorption, and we can also evaluate the mid-palatal suture maturation. And now, today we will talk about this. So first, skeletal age evaluation, skeletal maturity assessment based on X-ray of the hand and wrist. Nowadays, we don't use it very often because we need to make additional X-ray because we are afraid about the radiation and its influence on the human body. That's why we think about reduction of the X-ray to a minimum. That's why nowadays we use a different kind of X-rays. But in fact, this method by Bjork, Hang, and Taranger was and is now the best method to evaluate the patient's skeletal age. That we should have a special kind of atlas to recognize in what kind of stadium is our patient. What you should to know, we have characteristic changes and stages. For example, as this is the sesamoid bone, and when we can see the sesamoid bone of the tongue, when it's visible, but it's not always visible, it has place when the girls are allowed 11 years old and boys around 13 years old of age. So this is the time when usually we expect intensive growth of all the body. So it's the start of the growth. For us, if we are planning orthodontic treatment, it's very important to know that the person is at this age because we can start orthodontic treatment of the class 2. So we can, at this time, is the best time for advancement of the lower jaw and functional treatment. In this stage, for example, MP3 cap, here we have the most intensive growth, and MP3U, we have almost final stage of this growth, and RU, at this time we can be sure that the growth is already reached and we don't expect the significant increase in the length of all the body. So nowadays we as orthodontics don't use it often, but still is the very good method which is used on the world, but not as frequently in orthodontic
Are you recording or not?
As earlier. What we use nowadays, we assess the
I couldn't get it.
skeletal age when we look at the patient's cephalometric X-ray, and we look at the morphological changes in the cervical vertebra. So if we make cephalometric X-ray, we can see the soft teeth and the bone teeth of all the patient head, and additionally we should to see second, third, and fourth vertebra. First method was cervical vertebra methylation method, was found and was described by Lamparski. It was in 1970s. And he used this method for five vertebrae from second to sixth, as you see here. And he used it in 6 stages. For this method, Lamparski method, we need additional X-ray, the X-ray of the neck. So the patient need 2 X-rays. Face X-ray, it was cephalometric X-ray, and next the X-ray of the neck. Because here, in normal situation, we don't see all of this vertebrae. And nowadays, we don't use this method. Now the next method was the method Hasser and Farman. In this method, as you see, they use still 6 stages, but they use only vertebrae from second to third, to fourth, sorry, and they estimate the patient age. In this situation, we don't need additional X-ray. Only cephalometric X-ray was enough, so we have huge reduction of the radiation dose. Next method is method Baggetti, Franchi, and McNamara method. They, in 2002, changed this classification, and they found that, in fact, in the stage 1 and 2, nothing special happened for the patient. That's why they connect the person, the second stage, in one. So here we have this both stages. They was connected in one stage, as you see it here, and that's a kind of modification. Nowadays, the same authors in 2005 changed this version, changed this method, and we have at the moment still 6 stages. So the first and the second stages are not connected together, and this method is the method which you should know, because this method is in your book. It is on the page, because I check it for you. It's 100 page in your book, in second edition of Coburn's book. So this method you should know. You should know the stages, the shape of vertebra, and everything what you found in this book. You should know this, because you can expect a question during the diploma exam, during our quizzes. Okay, so what's the difference? What are the differences in these stages? First, we look at the shape of each one vertebra. It changed, and also we look at the lower border, as you see here. Here we have concave, this lower border, and here, for example, this border is flat. Cervical vertebral maturation stage 1 or 2. Okay, so this stage is the first stage. Usually we expect the stage when we have the person under 10 years old. So this is typical stage for this person. Stage 2, we have person a little older, but still we don't expect intensive growth at the moment. We are waiting for the spurt of the growth. Look now at the shape of the lower border of each one vertebra for stage 1. So as you see, typical for this stage is that the lower border is flat. And this is very characteristic. So we can give this picture for all the quizzes, and I think nobody couldn't have a problem to recognize that this is the stage 1. What else we can see here? Characteristic is, of course, for the shape of the vertebra, we estimate for the third and fourth vertebra. And here, the shape is trapezoidal, as you see here. Next, stage 2. And here, as you see, stage is still trapezoidal, but here you can see a little concavity on the second vertebra, the lower border of second vertebra. Stage 3. This is ideal time to start functional treatment because we expect that during this year, when we see this stage, the patient will be in the most intensive growth of all the body, and the most intensive growth of all the body is in correlation with the most intensive growth of the lower jaw. That's why this time is the best time for functional treatment of class 2. And look here, what here we should to see. It will be the lower border of the second and third vertebra. Here we expect that the lower border will be concave. Look here, lower border third, second and third vertebra is not flat like here, but we see here in both situations concavity. And the shape of the bodies could be still trapezoidal or rectangular.
It's okay. How about you?
Rectangular horizontally. This is important. And stage 4. Stage 4 is the situation when the patient finishes the most intensive growth. It doesn't mean that the patient will not grow. We still will observe the growth of the patient, but it will be not as intensive as earlier. So we can expect that still we have about 25% of all the growth. We can expect about 25%. But the most intensive growth had place 1 year ago. So here, this is not the good time to start functional treatment. Rather, this time we should finish functional treatment. For a girls, the spurt of the growth, it takes about 1 year. So it's very short time. And that's why it's so important to start this treatment at correct moment of this time. For boys, it is much more longer, and it takes about 2-3 hours. 2-3 years. Sorry. Now, look here. What here is typical for the stage: concavity on the second, third, and fourth vertebra, and the shape of the bodies of the vertebra is horizontally rectangular. Stage 5 and 6, it's information for us that the patient almost finished the growth. So we can expect 5 to 10% of all the growth at the stage 6. But there's information for us that the growth is finished. We couldn't expect the growth of all the body. And look at the shape of the vertebra. Here we have in the stage 5, the shape of the vertebra is almost square, and still the concavity are on the same vertebra. And in the stage 6, we see that the shape of the vertebra is vertically rectangular. So the height of the vertebra is bigger than the width of the vertebra. Okay, so when will be the best time to start functional treatment of last 2 malocclusion? So, according to Batchetti McNamara Franchi from 2005, from this method, we should start the treatment when the patient is in cervical vertebra maturation stage 3. So we can observe the concavity on the second and third vertebra. And here we can see the patient with her profile before and after treatment, functional treatment, and here her occlusion. Of course, this patient needs not only treatment, functional treatment with removable appliance, but it's the first step of treatment. The next step of treatment is the treatment with the braces. So we should use fixed appliance with braces to make correction of the teeth. Next question. So when should we treat the class 3 with underdevelopment of the upper jaw? So the best time for this treatment is the stage CS1, before CS1. CS2, sometimes it could be too late. So the best time is cervical vertebral maturation stage 1. So all of the bodies, lower border of all of the vertebra should be flat. And usually the children is under 10 years old. The best situation is to start this treatment before 9 years old even. Then we can expect better result. What we should do in this method of treatment, we bring upper jaw forward. This is extraoral appliance, is face mask. And this intraoral, usually the patient should have some kind of construction for this mask. It could be a construction with the screw in the middle like this one. And this we call a Hyrex, because very often in this kind of malocclusion, the patient also has transverse underdevelopment upper jaw. So the patient needs expansion of upper jaw. If not, we only use construction for face mask without the screw. Here hooks for the face mask, and here you can see we have elastics. Elastic joint is intraoral fixed appliance with extraoral removable appliance. And hooks should be at the level of the first deciduous molars, or because when the patient is under 10 years old, usually we expect that we'll have in this position deciduous first molars. Patient should wear this appliance for about 12 to 14 hours per day after school and during sleeping. When we can expect the result, when the suture between the maxillary bone and symptomatic bone, the suture is somewhere here, is still elastic. So in this situation, we observe forward movement of upper jaw, and after 10 years old, we don't expect forward movement of all the bone, but rather the protrusion and forward movement of the upper incisors and the tip in upper arch. Dental age evaluation. Also, we will study about this, so we can estimate the patient age when we look at the development of the germ, of the you will study about the Miriam method during our labs. For this method, we use panoramic X-ray or pantomogram, as you see here, and we look at the tip on the lower side of this orthopantomogram in the lower jaw. We start from the central incisor and we estimate the germ to the second molar. We don't estimate it for the third. We exclude from this method third molar. And the stages are from A to H. And here you can see the stages. We have also the stage 0. There are no visible signs of calcification. How it looks like here, we have 0. You can see. Very often you can see this on the orthopantomogram, especially when you make this orthopantomogram for the children who are about 10, 11 years old. Okay, and now, so you see all the stages. You should know how looks each one stage, and we have developmental stages for single-rooted tooth and multi-rooted tooth. And here, stage A, calcification of single occlusal points without fusion of different calcification. C, fusion of mineralization found that the contour of the occlusal surface is recognizable. For us, very important is stage D, because we have full, completely formation of the crown up to the cemento-enamel junction. So remember that stage D, completely formed crown. Now, stage E, we observe that the root starts developed, but is still very short. Then the length of the crown is higher. And next stage, here you see that the length of the crown and the root is almost the same at this stage. Stage G and H. Here, apex is closed. Here, we see that the root is almost completely, we observe almost completely formation of the root, but it is still open. Apical foramen is still open. The same situation is for multi-rooted tooth. But remember that you should know all of the stages, and you should know how to recognize each one stages on the pantomogram. We will do it during our labs. Now, if we know that, for example, central incisor, lower central incisor is in the stage B. So, lower central incisor here in the stage B. We have no information about this. But, for example, premolar, lower premolar, in the stage B, we have this value for this stage for boys. The same value will be for girls. For example, for molar, second molar, in stage C, we have this value, and this will be the value for girls. Now, for all of this tooth, we check for all the stages, we check the value, and we sum of all the value. So we add for each one tooth this value. We have different table for boys and different for girls. And now, when we achieve the result, the value of this result, we check in the table for boys and for girls. We have different table. And for example, we will have score, for example, 94.4. So the age for this boy, dental age, remember, it's 12 years and 2 months. So we can recognize the patient dental age. So we know the chronological patient age. We know the patient's skeletal age when we look at the cephalometric X-ray, and if you look at on the orthopantomogram, we can estimate the patient or this patient also dental age. And here look at the stages. So stage Z0 or O, and next stage A, here stage D, full crown formation. So in fact, you can estimate the stage for each one tooth. So you can look at each one tooth and you can estimate the stage of this tooth. But if we ask you about estimation the patient dental age, you only choose, and you should to add the teeth from central incisor to second molar in lower arch on the left side. Okay, now of course we use radiological X-ray to analyze dental and skeletal relationship of a skull. We use for this we use it when we are making analysis of cephalometric X-ray, where we have a lot of angles, and we achieve results. Then we make interpretation of these results. So we will talk about this more during probably next lectures. We can also use 3D cephalometry, but nowadays, because it's huge radiation, we don't use it very often for the patient treated by us. But as you see here, the precision of point determination is much more bigger, because you can, when we are not sure, for example here, sometimes we don't see that when we exactly should to put the A points, because this part is sometimes difficult for estimation, because we can see here the shadow of the patient cheeks. Sometimes we don't see the root of the apex of the root of the lower incisor, because in the same position is the root of the canine. But here we don't have this problem, because we can put this point in perfect position. But radiation is too big, and next problem, we don't still have the analysis for CBCT 3D X-rays. That's why it's not useful for us as orthodontics. For what we use this CBCT X-rays? We also use it to assess the position of impacted teeth, supernumerary teeth, when we want to estimate the present or absent the resorption, which are on the vestibular or palatal side. We can only use this kind of X-ray, because we couldn't see this resorption on the orthopantomogram or different kind of X-ray. Also, if we want to estimate the mid-palatal suture maturation, and sometimes to find the laceration of the root, especially root of the impacted tooth, to make decision about extraction of this tooth or bringing it into the arch. Here you can see impaction of the central incisor. Here you can see still deciduous tip. This tooth was impacted palatally, and this tooth has also a little delaceration, but also we have problem with ankylosis. The girl was very young, so we don't expect ankylosis at this age, but there also was ankylosis. So it finished with extraction. We start the treatment, we try to bring it into the arch, but in fact we finish with extraction of this tooth. Supernumerary tip or tooth, we also the best method to find where is this tooth is TBCT. You can see very small crown of additional tooth here just behind the central incisor, and it stops in eruption of this tooth. Sometimes I had this kind of situation that I don't see the additional tooth because it was so small on the orthopantomogram, but when I make a CBCT, this tooth was visible, especially if it's only at the stage of formation, because sometimes we have such a small part of the crown. It stops in eruption of the permanent tooth, but we don't know why, because we don't see this tooth on the orthopantomogram. And tooth transposition we can estimate like here. So we know that where is exactly the root and where is the crown of this tooth. And for impaction, so we know where the tooth is impacted, vestibulary or palatally, and we can estimate the present or absent of the resorption. And here you can see this is 2-2 lateral incisor, number 2-2, and here the canine, 2-3, and look here, you can see the resorption of the palatal surface of the root of the lateral incisor. You can see it also here. But this resorption was here is visible, but when I estimate the orthopantomogram, I don't see the resorption. I can expect that this resorption could be present, but I couldn't see it. Mid-palatal suture maturation. This is the rather new classification, method for classification of the maturation of palatal suture. You know that this is a very important part of the human body for orthodontics, especially when we have narrow upper arch, when we are thinking about the expansion, because during expansion, we are thinking about opening the palatal suture because we want to make expansion on the skeletal level. That's why we should estimate the maturation of this palatal suture. Stage A, B is typical for the patients before intensive growth. So it's for a rather younger patient, about 11, 12 years old. But also we can expect that the older patient will have the same stage because there's a huge variation, a huge irregularity in the closing of this suture. Especially if we have a person over 14 years old, we should think about this to check the maturation of the suture. So in these two stages, we shouldn't think about expansion only with appliances, orthodontic appliances. We should think about surgery-assisted rapid palatal expansion, because in this stage, the suture in this distal palate, here we have palatinate bone, is closed, and here all the suture is closed. So we can't expect that after our treatment by expansion, we opening the suture. Rather, we can expect that we push the buccal tip outside the alveolar bone, or we make proclination of this buccal proclination of the tipping buccal region. So it will be not a good result of our treatment. To avoid this, we can estimate it. Here we have information how to do it using cephalometric, not cephalometric, CBCT method. Okay, application of 3D techniques in orthodontics. So we can use this for diagnostic and for treatment. For diagnostic, as I told you earlier, it's in radiology, CBCT, 3D cephalometry, in documentation, 3D models, so digital models, as you see in our clinic, we have 2 scanners, so we can scan the patient, and you can see this model when we will be in the center of medical simulation. During our lab, we will work on this model. Also, we use this technique during treatment. We use appliances, like Invisalign splints. So intraoral scanners, scan upper and lower jaw. We can print these digital models. We can print it for and we can have diagnostic models for documentation, and also we can print this model and make on this model appliances. Invisalign splint, how it works. So we have a special kind for each one company which made these splints. We have Ortho, we have Sparks method, we have Invisalign. It has a program software to make clean check, to plan or the treatment. So here in this color we can see attachments. So if we want to change the position of each one, to, for example, we have rotation or derotation, or we can make intrusion or extrusion of the crown, we add attachments. The attachments are made from the low composite. We also planning the stripping. What this means, stripping? Stripping is the method of reduction of the enamel on interproximal surfaces of adjacent tooth. So if we need more space between for the tooth or tip, but we don't need extraction, we can plan the stripping, like here. And this is information. If you will change the spleen for next, you will need stripping, and computer give for you information where exactly and how big the stripping should be. There's also information on which spleens you need attachment. So you should go to the office, doctor or hygienist will make for you attachment, and then you should do wear the spleens and it will work. Okay, so thank you for today, and I will check a list. Do you have questions to the lecture?
Doctor, I have a question.
Yes.
For the presentations, I couldn't find them in the book. Like my topic 1. Do you have chapters that we can look for this?
Topic 1. What was the topic 1? Can you
Yes.
remember me?
It's the breathing issues, like the vestibular. Hold on, let me find the exact one. 1 second. It's okay. Okay, so my topic is breathing through the mouth, vestibular screen.
Mm-hmm. Okay.
And I was looking for it in the book, and I couldn't find anything.
Breathing through the mouth. If you have this kind, if you have this kind of question, breathing through the mouth. So first, you can check it in Profit Book. During my lecture was a presentation about this. What's happened if the patient is still breathing through the mouth. And I think that also in Coburn book there will be information what's happened with the patient who breathe through the mouth. But the best it will be if you use contemporary orthodontics William Profit. There is a chapter about this.
Oh, there's a whole chapter. Okay, I guess I'll just look through it. So, do we only have to use the book? Can we not use external?
You can use. What do you want to? But it could be also publication. But,
yeah, because like my sister had breathing through the, like she saw an ENT and she was breathing through the mouth and she had to get surgery. So I think I know I want to write some other stuff.
Yes, but you don't. I don't ask you in this to write me about surgery, about the treatment. Okay. It should be about prophylaxis. So not the treatment, prophylaxis.
Okay.
Only. That's why you have information about. So it will be. You should write about training of the lips, and for example, for this you can use a vestibular screen. So probably if you write this in the internet, you will have information. What is this vestibular splint? If you, it's Schenner splint also.
Schenner splint. Okay.
Schenner splint.
Okay, and then one other question. So I know you gave us that paper. So you wanted like 6 to 7 slides max. Yes. So the top of the slide needs to be like impact on occlusion. So that would be my top of the slide. And at the bottom, I would write what's the impact on occlusion when you have breathing issues, right?
Yes. Yes.
Okay. Okay.
On occlusion, on extraoral view. So if you look at the patient extraorally, what you see in your topic, you can write a lot of information about this. You will have many information.
Okay. Okay. Yes.
How I think change the patient face.
Okay. Okay. Thank you.
Thank you. Okay, so thank you for attention for today.